Hello, everyone, and welcome to episode 8, our final episode of #IGD Talks. My name is Raquel Simpson, and I will be your host for today. Just to introduce myself, I'm a practical nursing student, and I hold a master's in emergency management. I recently embarked upon this wonderful journey of gerontological nursing. In this podcast series, I will be introducing a number of special guests who will be providing invaluable insight in dementia care, dementia research, training, and education. Let's get started. Enjoy the show. Welcome to our audience. Thank you for tuning in. This is our 8th episode of this podcast series. And today we have a lovely guest, Dr. Lori Schindel-Martin. How are you today?
I'm very well, thank you, Raquel.
Awesome. So for our viewers, can you please introduce yourself?
Of course. I am Lori Schindel-Martin. I am an associate professor at the Daphne Cockrell School of Nursing at Ryerson University, and I also am a member of the Board of Directors of Advanced Gerontological Education, and was a co-investigator with Dr. Tricia Wu on the project that we're going to be talking about today.
Great. So just to start off, did you want to talk a little bit about your involvement in AGE?
Yes. I have been a member of an interprofessional collaboration, not-for-profit social service enterprise, and we have been working very hard over the course of about 14 years to develop an evidence-informed, person-centered, holistic program to help staff and students to understand what it means to be living with the behavioral and psychological symptoms of dementia.
Right. That's great. Now, you made mention of your collaboration with Dr. Wu, who is also a guest on our podcast.
Yes.
Maybe you want to elaborate on the project that you were working on and what your specific role was.
Okay, so Tricia and I were co-principal investigators of this project. And so the Retired Teachers of Ontario Foundation offered a granting opportunity for all of project teams that were interested in training the next generation of geriatric-oriented healthcare professionals. And so we came together when we saw this funding opportunity. I was interested in testing the e-learning component of gentle persuasive approaches, and Tricia and I were intrigued about how we could integrate this into a blended curriculum, with the e-learning being followed up by the Geriatric Skills Day workshop that we were able to do in April of 2017. And this has been a very exciting initiative for us both, and we've had quite a wonderful interprofessional group associated with the project as well.
Great. So share with us maybe some of the lessons learned from this project, or maybe what some of the final results and outcomes are showing.
Yes. For participants who were with both the e-learning program that they took ahead of coming to the Skills Day workshop that was offered about maybe 8 weeks after they had completed and begun the e-learning program, those individuals both reported that they had entered those situations for learning with a bit of trepidation because they didn't feel prepared to interact either on a social but also a healthcare relationship with people living with dementia. They had misconceptions, and they also had little opportunity to understand how they could modify their communication approaches, but also to recognize that it is a best practice skill to have that kind of communication ability, not a happy accident. And I think that that's one of the most wonderful, striking findings, that the students who participated recognize that when they see best practice in the clinical setting, and they go, my goodness, that healthcare professional's got a wonderful ability to connect, they recognize it's not a happy accident, it's purposeful, skill-directed, and it is intentional, and it is professional, and it's evidence-informed. And that, I think, makes it so much of appeal that gerontological practice is an amazing opportunity to be able to connect when there might be challenges that make that somewhat difficult to do without very specific skills. It's not just meaning that you demonstrate what a nice person you are.
Right.
It's far, far deeper than that.
Sure. And so what would you say to students who are in a professional healthcare program and maybe aren't sure what specialty they want to sort of venture into? What would you say? I guess this is the plug for gerontology and geriatrics. What would you say to that student that's kind of contemplating?
I would say, join us. We are a very purposeful, passionate, interprofessional group of people who have come together to make the quality of life of older people much richer. And we have talents, skills that require what we sometimes refer to as a high-level ability to integrate all your knowledges into geriatric intensive care. The individuals that we work with typically have an interesting way of experiencing health as their age is progressing towards the end of their lives, and they are historians. They have seen so many wonderful events that we haven't been party to. They can engage in robust conversation, humor, playfulness. It is an amazing opportunity to bring everything you know integrated into relational care. And it is wonderful. There's a lovely reciprocity and a win-win for the clinician and the person who you are working with to address their healthcare and healthcare promotion needs.
That's amazing. So getting back to the workshop that you made mention of for the project in which you were a co-investigator with Dr. Wu, can you please elaborate a bit more on the significance of the interdisciplinary interactions that took place during this workshop?
That's an excellent question. I think one of the things that struck me the most is that there was a documentation exercise that was led by Wanda Krasnowski at the University Health Network. And her interest is to help professionals, regardless of their professional disciplinary lens, to ensure that their documentation is based on observation and direct observation, interpretation of valid data rather than opinions, biases, and unfortunately the way we often in the past have stigmatized older people living with dementia who are experiencing responsive behavior that is sometimes in the literature referred to as the behavioral and psychological symptoms of dementia. That was very striking because we showed standard video clips of an older person with dementia who is displaying progression through escalating behavior, is becoming very upset and objecting, quite frankly, to that whole episode of receiving care because this gentleman has become incontinent and requires a change of the incontinent brief. And we asked people to write, after watching the standardized video clip, write down what you observe. Then Wanda delivered an excellent presentation on what should be part of an objective, professional, and useful progress note in a medical record for any person, regardless of what healthcare sector that they're being cared for in. And then we, after that, we repeated the exercise. They saw the clip again, and then they once again engaged in documentation. And so after that, they sat down together and compared and contrasted their knowledges, what they focused on from their professional disciplinary lens. And I think they could see that there's common information and good quality information that they can gain from each other from a responsive behavior lens. And that was very useful for them. And to be able to discuss interpretation of responsive behavior from their own disciplinary lens, I think those auxiliary team members who may not necessarily touch a person with dementia for intimate personal care have had a full appreciation of what that might be like to be engaged in feeding someone or transferring someone or performing incontinent care with that person, what that might be like.
Okay. Why don't we talk about the significance of GPA and why it's imperative that it become a part of curriculum and become a part of more programs within the healthcare disciplines?
Well, my colleague Daria Romaniuk mentioned this in her podcast series, I believe, and I would invite people to review that, but I'm just going to add that it's been very interesting that when I was a clinical nurse specialist in continuing chronic care and long-term care, I was always so interested in the fact that if students came to me to be their faculty advisor for a clinical placement, they would be sort of distressed because they didn't have any understanding of how to interact with someone with cognitive impairment, and particularly if they were upset with the introduction of a treatment. Bathing in particular is an issue of concern because nurses in particular want their residents to be comfortable, to be clean, of course, that their skin integrity is dealt with and maintained over time. And of course, if you have someone who is upset by being touched and their body space invaded and then clothing removed, regardless of how tender you are and how much explanation you give, I think that nursing students in particular were in a position that they just did not feel that they were prepared to know what to do. And I was really interested in having students have their elfin spirits, if you will, and their creativity just mentored, because really this is one of the most interesting nursing areas of focus that I think has such a huge potential for career development. And without having a solid knowledge base that's introduced to you in the very first components of your educational program, I think it's almost too late if you maybe get yourself prepared in your last segments of your program, because you may already have been so turned off by gerontology that you don't understand the potential of how absolutely marvelous it can be when you can reach across that gap and connect with the human being who you can develop a very wonderful collaborative relationship with. It's still possible for individuals, regardless of the progression of an irreversible disease process like dementia, their very self can be brought in, and their preferences, their habits, their soul, their identity is still there. And it's the role of the healthcare provider to bring that out. And I think that that is the piece that you can't really spark without the person having very explicit knowledge that they acquire in the beginning of their course, so that they can open themselves to the opportunity for the aesthetics of the practice. Right. Totally potential for it to be inextricably linked in your practice in gerontological specialties.
Okay, that's very interesting. That reminds me of the post-2013 publication that talks about the 12 aspects of the enduring self.
Yes.
Your comment there really just kind of brought that to light, that although this patient may have cognitive impairment, who they are, or the soul of who they are, is still there.
Oh, definitely.
And having those techniques and those strategies to redirect or to address an unmet need is so pivotal. Yes. in addressing that enduring self that is still there.
I love that term, enduring self, and I think that Post makes a good case that enduring self can flourish with all of those symbolic aspects of care, the aesthetic aspects of care, the embodied aspects of care, the relational aspects of care, of course the scientific basis of care, but it's really, for the most part, a much richer foundation that I think requires some intuitive knowledge. I'm really glad that you found that article in the literature search that you did, and that it's going to be embedded into further program development that we do with our intervention.
Absolutely. So it'll be very interesting.
Mm-hmm.
So moving forward, speak to me a bit about the vision that you have for GPA. Where do you see GPA 5 years from now?
I think GPA, Gentle Persuasive Approaches, as I mentioned, is a not-for-profit social service enterprise, and we're very interested in the notion of sustainability of learning. We also are interested in that Paris framework context, that there are many pillars to support sustained application of knowledge at the point of care. And I think what we're recognizing is it's the facilitation that blends with independent learning on the part of the student or the clinician. That is related completely to being able to link this knowledge and apply it every day. So what would that look like? I think in the future, technology has a tremendous capacity to allow you in the point of care to connect with, via technology, a clinical expert who could give you advice on how to tailor interpersonal care right in the moment. I think that potential is going to be totally amazing. From a content perspective, so what I mentioned a moment ago is sort of like the platforms upon which learning will be possible, with expert facilitation from a knowledge expert. But the content, I can see bathing is a curriculum that we're working on right now, because it continues to be one of the situational contexts that responsive behavior can be evoked. And so we know that we need to fill that gap. While a lot of the existing programs focus on what to do if a best friends approach or a communication approach is the answer, from 25 years of bedside clinical advisement and practice, I am very well aware that despite all your best communication attempts, there are still going to be those situations where it is absolutely necessary to touch that person living with dementia. So how do we do that in an ethical, aesthetic, technically correct fashion.
Right.
And then finally, my dream would be that we develop a curriculum that applies all the gentle persuasive approaches and person-centered care approaches to the understanding and teaching and responses for staff to use around sexually responsive behaviors, and helping to understand that better. That our current existing educational programs are quite limited in that regard.
Right. Also, what I found in the literature that there isn't very much information or very much publication on sexual responsive behavior in persons living with dementia.
That's right.
That I don't know if it's just it's too taboo, or people don't want to discuss it, or maybe just not informed enough about it. But there really is not that much out there right now to inform practitioners as to how to best deal with the behavior, for lack of a better term.
That's right.
In a way that the patient living with dementia is not a harm to themselves or anyone else, especially in a long-term care setting.
That's right.
Yeah.
That's right.
Yeah. So tell me a bit about if you could imagine this is the ideal situation, how would you like to see the field of gerontology go in the future? You can paint a picture with your words. What would gerontology and geriatrics look like?
That earlier than health profession programs, that students are exposed to communication strategies and dementia-friendly communities at the elementary and high school, secondary school levels. Yeah. And I think that I could see quite a wonderful implementation of gentle persuasive approaches in secondary schools, for example. I would start that first and help those students to be inspired by what would be the potential of engaging in a career where older people in communities and in the sort of governmental and policy perspectives, older people are such wonderful individuals who have much to share and are skill builders, community builders, and have a social justice conscience that makes them ideal to be engaging in educational opportunities with high school students. And I think this knowledge is really critical all across the public, actually. I think gerontology also has its components for social sciences, and of course there's a wonderful advancements all the time that are being published from social scientists, gerontologists, and I think health professions actually have a lot to catch up in terms of the context of the gerontologist and gerontology knowledges. So again, my goal would be that every undergraduate health profession program had threaded through every course in a very explicit way knowledges around what it means to interact with, care for, health promote, and provide end-of-life care to someone who is aging and is older.
Right. You know, it's really great that you mentioned that, because I'm thinking of two examples of that I read about recently where the specific community was actually already, people living with dementia were already integrated in a fashion to break down generational barriers. So one example was actually in Western Canada, and I can't remember if it was British Columbia or Alberta, but one of the things that they did was there were high school students and there was a choir, and what they did was they had the high school students perform with people who who were living with dementia. So the carers and the dementia patients were also in this choir. And part of that was, it was something that, depending on how far advanced the dementia was in the specific patient, they could still remember lyrics. And it was breaking down barriers for generations, because it gave the high school students the opportunity to be exposed more to patients living with dementia. And it also gave them the opportunity to learn about music from a different era.
Yes.
And it was actually quite effective when they were doing qualitative interviews and looking at the responses on surveys for, even in terms of the mental health, the changes, the positive changes in mental health for the carers, the positive change in mental health for the actual patients, and how that breaking down barriers, generational barriers, and allowing people living with dementias to not be isolated, but to be a vital part of the community, had great impact. And another example that I read about was, it was in Europe, and I cannot remember, it might have been Denmark, but I'm not 100% certain. But what they were doing was creating affordable living spaces. And what that meant was young professionals and or university students could live in shared accommodation with people who had dementia. So for example, someone could have a neighbor who was living with dementia or Alzheimer's, but needed at that point in time very little care. But what it actually did was it actually helped to save cost.
Yes.
For the government, in terms of the long-term care facilities that were built. And it also helped university students save money on living expenses.
Right.
And it also helped for the social component of patients living with dementia, because they would get to know their neighbors, they would have dinner together, they would go out for walks in the park. And so again, there was this whole notion of breaking down generational barriers, while making sure that people living with dementia were not socially isolated. And so that was pretty new. That was pretty new program that they had in place. But I remember thinking about that and thinking, wow, that's so novel, yet it's quite simple. It seems quite simple.
It does seem quite simple, and I think that it's in its simpleness that therein lies its power.
Right.
And I think, while relational care is considered something that should be there, I think that the importance here is that exchange and reciprocity.
Right.
And that there's something that both of those generations are learning from each other.
Absolutely.
And they're creating something beautiful as a result of that. So in the case of the choir, they're creating something that is going out from them each into that performance.
Absolutely.
And in making a meal together.
Yes.
That mealtime experience is very important, and when you can learn from each other as housemates, that is what an absolutely wonderful outcome that is.
Yeah, and one of the benefits in terms of reciprocity, one of the university students had said, like, they don't have family in the city that they were studying.
Right.
This person didn't have family, and so the fact that they had their neighbor living with dementia who would look out for them, so to speak, and say, oh, you came home kind of late, are you okay? Or I baked this cake for you, whatever the case may be. It was also meeting a need within the student that was away from their family and didn't have somebody looking out for them, or didn't have someone who they didn't think anyone cared enough. And here was this patient living with dementia meeting that need and filling that void for that university student. I thought it was phenomenal. I thought it was really eye-opening. Yeah,
I can see the excitement in your face, and I'm thinking that this experience of working on this project and hosting the podcast series, has this sort of opened your eyes further to the potential of what it could mean to be a gerontological practitioner when you finish your program?
I have been thinking about this. It's quite different for me because I actually worked in pediatric ICU doing clinical research prior to, so I'm used to working with people on the other end of the age spectrum. And so for me, this was really interesting. I see that there's a lot of opportunity for creative collaboration. There's a lot of opportunity for innovation.
Yes.
And it's very exciting to me. Even the fact that just the whole aspect of gerontology in its very essence cries out for interdisciplinary collaboration.
Yes.
It excites me because you have various people with different perspectives bringing various strengths to begin to problem solve, to begin to work with people living with dementias and their family members. Mm-hmm. And other informal caregivers, and find solid solutions.
Yes.
Not just another theory. I don't think we need another theory. We need valid solutions that we can apply in a real world setting that can greatly impact those who are living with dementia and those who will at some point be living with dementia, because it doesn't end here. It's generation after generation, and I'm hoping that as a healthcare community that we can find a viable solution and or cure or get more answers out of what does this condition actually mean? What's the etiology of it? Where is it coming from? Why does it impact one patient in this way and another patient in another way? And if we can find some tangible answers and some tangible solutions, I think that excites me the most.
You've raised a really interesting point, and that notion of interprofessionalism and the synergy and the excitement that comes with sharing ideas. One of the things that I think is really important is that whole area of development around non-pharmacological interventions. Absolutely. And that is not the purview or the mandate or owned by any single disciplinary lens. Right. And I have had the most amazing brainstorming sessions with occupational therapists, physiotherapists, the physician on the team, the geriatric psychiatrist, the dietitian, around how are we going to interest and engage this person who keeps getting up from the table and wandering during meal times, and they're not ingesting the amount of calories that we need. And sure, you could go to this thing where you throw protein powder all over everything, but it's so interesting and quite collegial to sit down and brainstorm around what we're going to do instead of using a pharmacological approach to reduce the agitation of the person. Everybody's got to put their head into it. And some of the outcomes, like feed this person and eat with them while they walk. And you got to involve infection control and quality management teams and risk reduction teams and nutritional viewpoints, and it's really quite amazing. And administrative leaders, is this best practice reasonable to put in place, and how are we going to do this? And some of my most amazing moments have been replacing the focus of someone who's standing at a locked, secured door unit, and regardless of whether there's a mural obscuring it, they're drawn to that space often, and they're upset. And we finally, in some organizations that I've worked within, let's just open the door and let's just walk with them, and let's circulate with them, and let's have with us a safe, nutritional finger food option that we can just give them as they're walking and exploring the environment. And we'll keep doing that, and we can get their protein and calorie ingestion up to a place that feels much more comfortable for us. So that requires everyone on board. And this is where interprofessional dialogue is essential.
Right. That's amazing. Wow. Well, thank you so much for this discussion and this conversation.
My pleasure. Thank you, Raquel.
Thank you. I think you've given our audience great nuggets of truth and a lot of food for thought. So,
as have you.
Thank you. And that concludes episode 8 of Hashtag IGD Talks. I hope you enjoyed the series and all of our guests. We had a chance to connect with current professional healthcare students in nursing and medicine, as well as educators and clinicians. Thank you so much for tuning in.